We further are directing efforts toward improving diversity in our society and to focus on the wellness of physicians, surgeons, and the mental health of our patients, two areas which we feel have been traditionally neglected in the medical community. So why join the OTA? Well, many reasons, of course, some of which are listed here. I think all of you who are tuning in to this wonderful course this weekend are interested in increasing your level of expertise, which certainly we afford a lot of opportunities to do that throughout the year. We focus on new treatment trends and controversies. We hope you're able to strengthen your own practice, your collaboration with others, and to improve your professional development. Some of the member services are listed here. You're probably all very familiar with one of our journals, the Journal of Orthopedic Trauma. And many of you probably are aware also that a few years ago, we founded OTA International, which is an open access journal with a slightly different set of articles, focusing more on humanitarian work and research on a global level. We also started OTA Online, a web-based resource housed with a lot of educational opportunities directed at surgeons at all levels, but with an emphasis on community surgeons and surgeons in training. I will show you more about that in just a moment. Other member services are listed here, a variety of complimentary webinars, podcasts, and career resources, something for everybody. Our membership is just over 2,700 people, most of which are surgeons in practice. We currently have 26 members from India, and international members comprise about 15% of our society. We have a membership deadline coming up later this week for a cycle that happens twice a year, as is shown here. There's further information available on our website if you're interested in joining us, and we hope you will consider that. In order to be a member, international member, the qualifications are listed here. You have to be certified by your own licensing body, maintain a full and unrestricted license to practice medicine and surgery, be a citizen or resident in the country you are applying from, and to be a member of your country's trauma organization, in your case, the Trauma Society of India. One of the main things that we've spent a lot of time on as a society in the past few years is OTA Online. If you haven't had a chance to look at it, I would encourage you to do it today, www.otaonline.org. There's quite a bit of information there. Some of the key features are listed here. We find that technique videos and videos on demand of our annual meeting and other courses are things that are very popular and have served to educate surgeons around the world. The opening pages looks something like this. It's very easy to navigate, to find what you need to do, whether you're brushing up on a new technique, learning about some meetings that have just happened, attending webinars, or looking up a new dissection that you're going to do for a case next week. Everything that you might need in the way of orthopedic trauma education, you can find here. The two official journals of the OTA are also shown. The Journal of Orthopedic Trauma, which has had a long, rich history of premier research presentations in the trauma community with editor-in-chief, Dr. Roy Sanders, and our newer journal, OTA International, which is an open index journal, also indexed in PubMed, and is led by editor-in-chief, Dr. Emil Shemitz. Further resources directed at residents in training are a collection of lectures called the Core Curriculum. This is updated regularly on a regular schedule by many of the surgeons who are members. It's very popular amongst the residents. They use it for education in their own programs, to share with each other and with their grand rounds at their hospitals. And a lot of surgeons on a worldwide level also use these in order to continue their education. Some of the presentation topics are in the areas that are shown here on the lower half of the slide. Other educational opportunities abound. During the COVID pandemic, we started something called Fracture Night, where one evening a week, which would be morning for you guys, there's hundreds of surgeons who get on and discuss cases on a different topic. It's become very popular as a way of engaging and interacting to showcase presentations around a given theme. And we plan on continuing this even though the pandemic is starting to wind down. There's also a variety of other formal courses, some of which have been made virtual over the past year and a half, but many of which are anticipating going back to a live format once the pandemic continues to go away. We also look forward to continuing all of our webinars, podcasts, and an online discussion forum, which is a terrific way to share cases and exchange ideas on that platform. Can be linked to either through OTA online or through the OTA website. We also support a lot of research. As you saw previously, it is one of our cornerstone pillars. Each year we have grant cycles and offer a lot of grant opportunities. In 2020, we funded over $715,000 US in research grants. Many of these are clinical grants, many are basic science grants. There are also grants awarded at the resident level and grants direct specifically to our international partners. International OTA is a conglomeration of 20 international societies, which are shown here, and include the Trauma Society of India. This has fostered the opportunity for our international partners to interact more directly together, have their own meetings, and to foster research collaborations on a more organized level. For the year 2021, we have some additional educational plans. During the American Academy of Orthopedic Surgeons annual meeting, which has been rescheduled to late August and early September, we will be offering a trauma update. At that point, we will show highlight papers from the OTA 2020 annual meeting, an orthopedic trauma boot camp, giving updates on emergencies and urgencies in orthopedic surgery. We'll also have special presentations on the fixation of osteoporotic fractures and a couple of presentations noting the effects of moral injury and trauma call, and one keynote speaker speaking on diversity within orthopedic trauma. We further look forward to our annual meeting, which will be held in Fort Worth, Dallas, Texas, in late October of 2021. This annual meeting will follow somewhat of our traditional annual meeting format for those 3 days in Texas. A variety of pre-meeting courses also listed here will be held, and we believe the research content will be quite good. We've received over 1,300 abstracts, and the program committee spent a lot of time selecting presentations for podium and poster venues, and really have awarded those speaking obligations to people from around the world. And so we're hopeful that it will be safe and feasible for a robust attendance for this live meeting in person in Texas in October of 2021. We hope to see some of you there. Again, on behalf of the OTA, I truly thank you for the opportunity to partner for this educational event and to indulge you myself this morning with some of the highlights of our society. Thank you.
Thank you very much, Dr. Heather Vallier, for your oration on what are the benefits of becoming a member of OTA as an international member. Thank you very much. Now, for the next talk, that is Breakthrough Innovation in Trauma, I have the pleasure of inviting Dr. Kevin Tetsworth from Sydney. I know it's 23 hours there, just 1 hour before midnight there. And thank you for staying late night for giving this talk. And he will be talking on osteointegration as the definitive post-traumatic reconstruction solution. Yes, Dr. Kevin, only yours now.
All right. Let me just share the screen here 1 second and get things rocking and rolling. So again, many thanks to the organizing committee for inviting me for the OTA insignia and our Indian Orthopaedic Association. Let me just see, where's my, yeah, there we go. Good. We're ready to go. Anyway, many thanks to the course organizers. I had the great honor of participating in a session last night on infection that was really very, very eye-opening for me as well. I learned quite a bit from some of my Indian colleagues and things, and also a great pleasure to share the symposium session this morning with Heather and with Josh Gary as well. I will say that just to start, again, I'm sensitive to the impact of the pandemic, both across the US and currently ravaging many parts of India. And we in Australia have been relatively spared. It doesn't mean that I'm not sensitive to the issues, that I do look forward to the day very soon when that is under control. I'm optimistic it'll come under control quickly, and that we'll all travel again and be able to enjoy each other's company very soon, perhaps later this year. Now, I'm going to talk to you about osseointegration, and I won't waste a lot of time with data in this talk. This is really going to be inspirational. It is innovation at its finest, and this is a new revolution that is coming your way, and it is going to be a paradigm shift, I believe, in the way that we manage amputees in general, and also approach many problems in terms of limb salvage and reconstruction. And it gives you opportunities to do things that heretofore you would not have believed possible. And I will show you some examples, and I will make an analogy here that osseointegration will have the same impact that Ilizarov did 30 years ago, when we were able to take on new problems and approach things with a different way of thinking. So again, I'm from Australia. I work at the Royal Brisbane Hospital, as well as in Sydney at a limb reconstruction center at Macquarie Hospital. And these are my colleagues there. And we have a limb reconstruction unit. But my biggest partner there is Munjid Al-Mudaris. He's an Iraqi surgeon who emigrated to Australia 20 years ago. And he has pushed this to the limits, and he is the #1 surgeon in this regard in the world. And I've been working together with him for the past 6 years, and I'm one of the other leading surgeons in this area. These are disclosures. I have none that is related to this. Munjid does manufacture and develop various implants and things. So he does have disclosures, although he's not giving the talk. I just think it's fair to point out that he does have associations and contracts with the various implant manufacturers. Now, what I want you to do is free your mind. I want you to open up your eyes and have a fresh look. And I'm going to invite you to walk through the door, because this is what is possible. This man is an amputee, and you cannot do this wearing a socket. And honestly, I can't remember which side is which. And I would challenge you to tell me which side is which. One side is an amputated leg. The other is not. And yet he's able to push fully and immerse himself in muddy water, not worrying about wearing a socket. He is not limited by using a socket-mounted prosthesis, and he can push with all his might, as you see. This man is swimming. He is also an amputee. You cannot do this with a socket. Not possible. You can't wear fins. Sure, you can swim. You can swim around with one leg. Yeah, but it's a lot easier to swim with two legs, I'm pretty sure. All right, this is Munjid, and he's really an arthroplasty surgeon who has applied many of the principles of arthroplasty to the way that we do osseointegration. So this is a direct skeletal attachment of a prosthetic limb, and it opens the door to what we would consider robotic limbs. And I will talk to you at the end about targeted muscle reinnervation. And he was inspired as a child when he saw the Terminator, the movie. Now, that happens to be a picture of me with Arnold maybe 26, 27 years ago, unrelated to anything to do with osseointegration, other than that this was Munjid's inspiration to pursue this. Now, where do we stand? How do we maintain function after amputation? It turns out that Ambroise Paré, 500 years ago, first invented the socket-mounted prosthetic limb for an above-knee amputee. And there is a current modern type of socket-mounted prosthesis. Yes, it uses different materials. It's not made of wood anymore. It's made of carbon fiber and various other high-tech materials. But in fact, the design is very similar 500 years later. Unbelievable. So what's our goal? We would want something that's comfortable, easy to use, lightweight, durable, stable, cosmetic. What's the reality? These things are a pain to use. They're uncomfortable. They take time to put them on and off. They're relatively heavy, and they require replacement frequently, and patients basically don't like them. So osseointegration, it comes from this term of making the bone integrated into and become one with the implant. And we're very familiar with this from arthroplasty. This is a total hip replacement. This is done all the time. Bone grows onto titanium. And how do we know this? Because of the arthroplasty and the dental applications. And so the difference here is that we're talking about having something that is percutaneously connected to an external endoprosthetic limb, but it is attached to your skeleton. Now, transcutaneous implants, sure, it's an attractive option in some patients, transcutaneous devices, but they're not for everyone, and you can't overdo it. And so it's a lot of it has to do with your patient selection and the indications, and we have a very rigorous protocol in terms of who's eligible, who's not eligible, and we work together with a clinical psychologist who helps us make that determination. This is a quick sort of a stylized video that just shows you when it was done in 2 stages. It's no longer done in 2 stages. Now we do it in 1 stage, but basically it's very similar to what you would do for an arthroplasty. You ream and you get a press fit of a porous coated implant. It's the same as a Wagner style stem. It's just put in, instead of putting it from proximal to distal, it's gone from distal to proximal. And when we did 2-stage procedure, you came back and did this 2nd stage to create a percutaneous opening. Now we do it all in one procedure. We implant the titanium implant, and then we create the stoma immediately. So we've had a much better outcome doing that. What do we do this? We eliminate the socket. And this is a young man, 18 years old, who to this time, until this point, was wheelchair bound. Now he's able to walk. And this is at his 12-week mark. And it's the first time he's really walked independently without using crutches and things. But that's the goal, is to get them walking full weight bearing by 12 weeks. This originally was developed. The fact that titanium grows so well to bone was first noted by Per Ingmar Brannemark, a Swedish dental surgeon, back in the mid-60s. And his son has become an orthopedic surgeon and has applied this same technology. So this is a well-proven technology, and this is used in millions of implants, in dental implants already throughout the US. I think there's going to be, what does it say there, 2.4 million dental implants in 2020, just in the US. So this was the Swedish implant, and in fact, it is very similar in many respects and in design to the dental implants. But it's cannulated, it's titanium, and it's a screw type device. And we believe that this is not the best for skeletal applications. The Germans brought in the ILP, which is a cobalt chrome press fit device. And Munjid had actually done a fellowship in Germany and then learned from that and melded together the two concepts of titanium with press fit. And this has now become the OPL. And this is really very much analogous to a Wagner stem. It's press fit and titanium solid, and it seems to work extremely well. I will emphasize this is a multidisciplinary team, and we use the anesthetists, pain physicians, the prosthetists, the physiotherapists, a clinical psychologist, and we all meet together in a single multidisciplinary setting to evaluate patients to determine who are the best applicants. So we have published protocols in this. If you Google my name or Google Munjid's name, Munjid Al-Muderis, and you'll come up with the protocol and the various outcomes and the data and things that support this. Worldwide, now we need to update the numbers. I forgot to do that for this, but now it's closer to 1,200 osseointegration cases have been performed worldwide, and it's well over 900 of those have been done by our team from Sydney, and most of these have been done in Australia. We do an outreach program to Baghdad in Iraq, which currently is on hold, but that is another place that we are very actively performing this type of procedure. These are the members of the team, and I won't delay things by going through that. Only to point out here, the eligibility criteria includes principally people with socket-related problems. Someone who can't use a prosthetic limb or has a lot of difficulty with it is our best candidate. And it's about 25% of all amputees. And if in the US alone, I believe there's 1.6 million amputees. That's maybe 1.9 million now. So it's close to 500,000 amputees that are struggling to use a socket. So they are our best candidates. We'd like them to be non-smokers. We insist on that. But in fact, in Iraq, 98% of them smoke. It doesn't seem to be a problem at all. What are the contraindications? Currently, it's peripheral vascular disease, although we do have a series of patients over 30 with peripheral vascular disease or diabetes. And so this is becoming less of an issue. And really, socket-related problems, that's the primary indication. Post-operatively, they begin loading almost immediately. And that is a graduated program of increasing loading that takes place over the next 12 weeks. But they start phase 1. They use this little short, stubby attachment and use a bathroom scale to load 5 kilograms and on the first day, and then gradually 5 kilograms every day subsequently until they reach 50% of their weight. That's the initial part. And there's a standard sort of protocol that we use for most patients. There are certain patients, if they are elderly and osteoporotic, middle-aged women, young men, we also put on the slower protocol because they have a tendency to just get up and want to run right away. So we slow them down. So 5 kilograms per day, and it only increases 5 kilograms every week until they reach that point, because you need to slow some of these people down to allow the implant to grow into their bone. And that's 20 minutes twice a day till they reach 50% of their body weight. And then they begin working with their light leg, which is phase 2. And that starts on about day 14. And they learn to ambulate with crutches and work within parallel bars. By phase 3, they now have been fit with their definitive limb, and they get a laser alignment, and they work in parallel bars before they begin to walk with 2 crutches. And they do that for the first 6 weeks, and then with 1 crutch for the next 6 weeks. And by 12 weeks, they're walking independently. Now, I will show you that this is the same patient. This is before and after osseointegration. And in bipedal stance, long-standing x-ray, on the left, that patient is wearing a socket. And you can see the position of the hip is very weak. The residual femur is abducted in that socket very dramatically. And this is a universal finding, perhaps not always as dramatically, but almost always it is in that position. It is difficult to fit any better than that. Sometimes you do have patients that get a better socket than that, but this is a very typical sort of finding. It puts the hip in a very weak position. Whereas you see, once they have osseointegration, it immediately restores alignment, and the hip is in a more mechanically advantageous position. So you get normal femoral alignment. Here we see an abnormal gait with a socket. This is the same patient. This is almost immediately after. This is at 4 months after he has had osseointegration, and you can see the dramatic change. You don't need gait analysis here. Everybody in the audience should be able to see the circumduction of his limb in the left with a socket and how well he walks on the right. Most of these are for trauma, and that's why it is this ultimate post-traumatic reconstruction. It's in concept, as much as Charlie introduced total joint replacement, this is total limb replacement. And where do you have the worst sort of limbs that can't be reconstructed? In a war zone. And because IEDs and landmines and war injuries, these are extreme high energy injuries. And with the advent of body armor and things, now people survive, but they have terrible injuries that are otherwise unreconstructible. So there can be bilateral, they may have extensive heterotopic bone, or they have extremely short bony residuums, so they can be very, very difficult to fit. And a bilateral above knee amputee, over 95% of those are unable to use sockets more than 2 years. Within 2 years, they just give up and they sit in a wheelchair. So we go to Baghdad, we go to Iraq when possible. We aren't able to go right now. I love this, that you look in there, the weather report in Baghdad is dust. And that's how it gets sometimes. But we go around under very, very heavy guard. We're protected. We're in armored vehicles. But we're in the green zone now. They've gotten rid of the green zone. It's a bit harder for us to go back and things. But we won't belabor the point. That's one of our operating lists for a day. And I think there's 26 cases on there. It's hard to make out. It's 3/4 of it is Arabic and 1/4 in English. But we bring a lot of gear with us. We bring 600 kilograms of gear with us. So you have to pay a little excess baggage fee to bring that all in. But there are a lot of amputees. Iraq has the most amputees per capita in the world. and we provide a service for them. And this is immediately post-op or within that first week post-op. You can see the quality of the stoma, and it is a good outcome for these patients, particularly people with bilateral amputees, or as you see in this gentleman, a very short residuum. That tiny tibia on the his left-hand side would be very difficult to fit with a socket. This is him within that first 2 weeks post-operative, and the team there has gone on and become very proficient in prosthetics and fitting them with these more sophisticated endoprosthetic limbs. Some of these cases are, again, difficult and challenging. I won't get into how we manage upper limb compared to lower limb, but again, this can be a challenging condition. And here we often use we call targeted muscle reinnervation, where you can reinnervate. You can take the muscles of the nerves, explore the brachial plexus, and transfer nerves across to remaining intact, functioning or active muscles. They're not actually functioning because they're not attached to anything, but they will still fire. And you can find portions of muscles that you can reactivate with the various components, median, ulnar, radial nerve, for instance, musculocutaneous nerve, and then teach the patient to use portions of his muscle to activate a myoelectric prosthesis. So this is what's coming. Here is another very extreme example of the type of post-traumatic reconstruction that now becomes possible. Until now, this was hopeless. And in fact, fitting this patient with a socket, also hopeless, not possible. These patients cannot use a endoprosthetic limb very effectively, particularly if you look at this patient. He has a huge soft tissue mass there and no hip. It's a hip disarticulation. How is he going to power that? How is he going to wear a socket? Not possible. So what's our answer? You can use the LC2 corridor, just like putting in that pelvic screw right into the sciatic buttress above the sciatic notch, greater sciatic notch. So we target this with a guide wire and then ream up that corridor. And I believe in this patient, we put an 18 millimeter prosthesis in. So it's the same femoral prosthesis that we used. I think we may have cut off 2 centimeters on the end, something along those lines. But we have done not a lot of these cases, but we have done some. And so far, we have been very encouraged by the early results. And here's his post-operative film. And he is now, I will say, a year and a half post-operative. This is him very early on. Here you see a video. He needs to move his pelvis through his lumbosacral spine to activate this device. And unfortunately, I don't have the video of him within this talk. My apologies there. But he is able to walk independently with a stick. And he can get down on the ground and he can stand up independently and functions at a very high level. So yes, he is extremely motivated, but this reconstruction is not otherwise possible. It's simply not possible. Our results there are very encouraging. And so this is taking things into what you would consider a relatively austere environment. It is not the highest tech, and it is not fit out with all the latest, greatest. This is a relatively austere environment. Most of these patients are smokers. Despite this, there's a very, very low rate of infection. None of these have been infected and need to be removed. And this man that you see here walking, that is bilateral transtibials. And he essentially walks with a normal gait. Again, with socket prosthesis, this is very difficult. So he was a single stage bilateral transtibial, December 2017, and there he is, ambulating independently, normal gait, 3 months later. This is another activity that you can do. It would be very difficult to do this. I can't imagine someone with a socket really being able to pedal this aggressively. They might be able to cycle for limited distances and at a slow speed with a socket-mounted prosthesis, but certainly not with a very high AK. So by reducing or eliminating the socket, you reduce socket skin interface problems, improve function and prosthetic use, and improve patient quality of life, which is really the main goal. You want to get these people back to active members of society, back working. And the message that comes to us from patients is that for the transfemoral amputees that have osseointegration, it gives them their life back and their mobility. And for the transtibials, now we are just in the process of undergoing review for our 2-year follow-up for the transtibial patients, over 100 transtibial patients. It gives them their limb back. They feel like they have a normal limb and they go on about their business. So the benefits are quality of life, prosthetic use, body image, walking ability, activity, return to work, many, many benefits. An unexpected benefit is something called osteoperception. And because it is attached to your skeleton, you are able to feel whether you're stepping on grass, carpet, tile, uneven ground, gravel, sand, snow. We don't really know about snow because Australia, Iraq, not a lot of snow, but I would imagine they'd be able to tell snow. And this, you don't teach the patient, they wake up with this ability. So an amputee, even a very good amputee, walking in the dark on an uneven surface will almost always fall. Amputees fall a lot, even very good, very mobile, and very athletically gifted amputees will often fall in the dark on an uneven surface. They can't feel when their leg hits the ground. When they have osseointegration, they get osteoperception instantly, and then they're able to walk in the dark. We ask them not to run for the first year. We'd like it to be fully osseointegrated, but it's a challenge to slow some of these people down. They want to get up and go out and do everything and resume their normal activities. And so running and jogging around, that's why they have the osseointegration. That flex foot, the carbon foot that you see there on the right, is not a common choice because it vibrates a lot, and that vibration translates and is transmitted directly to the skeleton. So most patients prefer not to have the flex foot, that carbon fiber foot. Again, these are kind of activities. It would not be possible to use the ergometer, the rowing machine. I can just imagine if you're in a socket, you would just keep going right off the back there. There'd be nothing holding you to the machine. You might come right out of your socket. So that would be a challenge. I'll just finish here with a few clinical examples, some inspirational examples. This woman was a transtibial amputee for 2.5 years. She's 2.5 years post-op to a dysvascular patient and on immune suppression for Berger syndrome. So not a great candidate, but she has been able to return to work. This woman had a very, very short stump. And Munjid did a very clever thing here. He connected it with a total hip. He took the femoral head, attached it to the end of the remaining distal femur there. So he did this femoral head transfer and then did a total hip into that. This is her at 5 years post-op. She's gone back to work. She works in the hospital. But yes, we have really good success doing a combination of osseointegration with total hip replacement. This did not work out so well with total knee replacement. And so we've abandoned that as a strategy, even though there is a paper that's been published with early results. I think at 2 years, 7 out of 7 patients were doing well. We since have discovered this is not our best option. It is very easy. There's a number of different ways to connect, but donning and doffing the endoprosthetic limb, this is a number of different techniques. This is with an Allen key sort of technique, but you can also see the quality of the stoma in this patient. So very benign appearance. And this is, again, a transfemoral. And have a look at her stoma. So about 75 to 80% of patients have very nice stomas like this. Not everybody does. And we work hard to make a really nice cosmetic stoma. We limit and cut back as much soft tissue as possible. The less soft tissue, the better the stoma. But they get this rotational control that you cannot get with a socket. This was a bilateral transfemoral amputee. He's now 5 years post-op. And this is a surprising way. That boot you see there, I think that's Prince Harry's boot. He had come for a visit, but this patient, those are not powered knees. He just pushes his feet together, and I'm not even sure, I still don't quite understand, but by pushing his heels together, it causes his knees to actively extend. This is the sort of typical gait. of a patient, and we leave that one leg a little short, as you always would in an amputee. You leave the endoprosthetic limb just a little bit short. Normally, she walks a lot better than this, but yeah, she's doing fine. This is a dysvascular patient, and it's difficult to even tell which side is the amputated side. I think he's going to pull it up for us. There you go. So we've had great success really in elderly amputees, a number of people, octogenarians over the age of 80. This woman also wheelchair bound, and we have quite a number of wheelchair bound patients, virtually all of whom are now ambulating independently. Some may use a stick or a single crutch for very long distances, but generally they walk independently. This is a young man with a transfemoral amputee, previously wheelchair bound. He's in his early 20s, but he's more agile than me. I'm tempted to get one of these because I can't get up and down off the ground like this. So it's this ultimate combination of medicine and engineering, and it is a great option for 25% of amputees, those with very short bony residuum, poor soft tissues, other issues wearing a socket. And it's really good for the transfemoral amputees, and we find, again, also very good for bilateral amputees. And I am going to now embark on a different quick discussion of targeted muscle reinnervation for amputees. And this is something that was really pushed by a fellow, Oscar Asman, a plastic surgeon from Vienna. And he primarily uses this in the upper limb, and you transfer remaining nerves, ulnar, median, radial, musculocutaneous. Those nerves are still there, even though they had amputee. And sometimes when you go back and do these brachial plexus explorations, there are so many neuromas. You'll open it up and there'll be 35 or 40 neuromas, and you need to do a lot of sorting through. I mean, the first time I did this, I thought I was going in and going to do this nice anatomic dissection, and it was going to be like it was in the textbook. No, this is like you open it up and there was popcorn. There was 40 neuromas there. It was quite a shock. But we sorted it all out, and you find the important roots and trunks, and you transfer them, and you can put them into other intact living muscles and then create areas. But you have to avoid crosstalk and other things to keep the muscles that get activated by these nerves as a fiber from chattering to one another. So they need to be relatively independent from one another. And even though we have robotic arms, you have myoelectric arms with 16 channels. Really, we don't need 16 channels. We just need 4 distinct channels, and we will go from there. But this is something that is really coming along leaps and bounds. So far, we don't have a huge experience with it. Certainly not the 800 patients that we've done in the lower extremity. I think we've done about 30 upper extremities, and probably the ones that have had targeted muscle reinnervation, it's closer to 10 or 12 where we have really gone full out with targeted muscle reinnervation to power a myoelectric prosthesis. So is this something in the near future? How far away is this concept of a mind-controlled bionic arm, this science fiction concept? In fact, this is a project that was undertaken by DARPA, the U.S. military, and the University of Pittsburgh. So Johnny Matheny, I saw him Chicago. It's May 2016, 5 years ago. I saw him, and unfortunately, I didn't make a video of him, but he is one of the very first patients to have what you would consider a thought-controlled upper extremity, an endoprosthetic limb, combining targeted muscle reinnervation and osseointegration. And one of the big problems with the myoelectric powered prosthesis is the weight. And so by attaching it to the skeleton, they don't have to carry it anymore. It's not like they're carrying around a bowling ball all the time. It's attached to their skeleton. So this is a big advantage. And in the near future, I am optimistic we will actually provide a sensate endoprosthetic limb. This is the dream, and this is the science fiction, but it is coming, and it will happen in your lifetimes. So this is an active project together with the U.S. Department of Defense. Kyle Potter, Jonathan Forsberg worked together. They come out and visited us in Sydney. Rob Rosbrook from Hospitals for Special Surgery has also come out and visited and spent some time with us. And these are many of the other pioneers that have pushed this. Rickard Brannemark from Sweden, of course, first introduced this about 30 years ago. So 1990, I believe, was his very first patient, Eric Axe. All right. So I think that we won't get into any other conclusions other than to say that this is here. It is a reality, and complication rate is very acceptable. The superficial infections are relatively common, but treated with oral antibiotics. Deep infection is relatively rare. Few loosening of any implants for infection. And periprosthetic fractures, it's at about the same rate as it happens with total hip replacement, which is 6 to 7%. These are, though, just our early and early to midterm results that we're publishing now. But infection is manageable. I think that the questions are, will this be something that becomes more generally applicable for the diabetic patients and the dysvascular patients? And in the developing world, will the same rules apply? So as we go into the future, I've been looking at limb salvage for the past 75 years. It seems, I've had to look through it, but where we go with the reconstruction of amputated limbs is going to be a huge part of what we do moving into the next 2 decades. And Abraham Lincoln said it best: the best way to predict the future is to create it. And I'll leave you with this thought that I want you to free your mind. Those of you familiar with the Matrix, I want you to abandon the constraints and the limitations that you have brought with you today and recognize that there is so much more that we'll be able to do in the near future. Thank you.
Thank you, Kevin. That was really an eye-opener regarding the breakthrough innovations you have done. Since we are ahead of time, we have 8 minutes still. So I would request the other panelists here, Manish Agarwal, you can take over and ask questions, because Manish is a oncologist here, and he has a lot of questions regarding its usefulness to hindquarter amputation. Over to you, Manish.
Dr. Tetsworth, this was a very stimulating and a wonderful talk, and congratulations on the fantastic work that you've done. Now, a few questions from my side is, can you do something for a hindquarter amputee, which has been a bigger challenge than the hip disarticulation? I mean, that itself is a big challenge. So have you had any experience with the hindquarter amputee? The second question would be that what happens to people who get a complication like an infection? How easy is it to salvage the situation for them? And my last question is that suppose we want to bring this technology to India for our patients, how do we go about it?
Yep. The first question, as to hindquarters, we have one hindquarter that we are actively designing particular implants. It'll take a custom implant, the standard implant. So with the hip disarticulation, we use a standard femoral implant and we just put it in. And that's a technique related thing and not an implant. For a hindquarter, you would need a separate, different type of implant that we are actively looking at creating for one particular patient. And based on the experience that we have with that patient, we will be able to move forward and give you more information on that. So I think that that is certainly a possibility, and I see no reason why we can't do that. The issue of how we manage infections. So it turns out 16% of patients have infections. Almost all patients in the first 3 weeks have at least some sort of low-grade infection. It turns out that every opening in your body, eyes, ears, nose, mouth, anywhere else in your body, has normal bacteria and is colonized. And we feel the same way with the stoma. And until the bone integrates, there is also this potential for that to become colonized. So that race through the surface, we want really good solid integration of the bone. And if that occurs before bacteria can set up shop, then you don't have a long-term infection and you don't have a lot of drainage. And this is the 80% of patients that do extremely well and have very few problems or infections. About 16% to 18% of our patients do have episodic low-grade infections that we manage with antibiotics and things, oral antibiotics. I'll say 6% need IV antibiotics at some point in the first 2 years. When we've looked at that, 6% need IV antibiotics, and about 2% need further surgery, either a stump revision or modification of the soft tissues or debridement or things like so. And the number of patients that need revision for loosening is well under 1%. It's closer to, it was 0.6% the last time that I checked. That may not be an accurate number. The last time I checked, it would have been 8-9 months ago, was 0.6% need. And so when we take out an implant, a loose infected implant, we do, as you would with a total joint, you do two-stage revision. So you take it out, we put an antibiotic rod back in there, just a Ilzarov threaded rod coated with antibiotic methacrylate, let it sit for 6 to 8 weeks. We give them antibiotics. And at about the 10-week mark, we come back and just reimplant. And we've had very good success redoing that in almost all cases. And we're putting together the data and about to publish a paper on revision of osseointegration for infection. So this is coming. The information we are gathering now and putting it together. The hard thing is to revise an implant that breaks and is well integrated. That is a challenge. That is a real challenge, because that can take you 6-7 hours to core out the broken bit of the implant. I mean, because they are seriously grown into, and you have to approach it from the bottom. Munjid has created these. He's very clever with this, and he has created these special cores that go over from the distal end up and from the proximal end down. And eventually you can get them out, but we have taken as long as 7 hours to take out one of those. But that can be a challenge. Taking out a loose infected one, this is easy, as you might imagine. The other thing is now that not only do we do target muscle innervation just for activating a myoelectric prosthesis, in the lower extremity, we use it all the time, routinely. We would have done 110 or 120 cases now, target muscle innervation to manage pain from neuromas, or phantom limb or phantom pain. And in fact, we also treat patients with CRPS, amputation with osseointegration. We've had a lot of success. So as an adjunct to management of amputees with neurogenic pain, also an important measure.
So majority of the problem
how do we bring it to India? There is one of Munjid's fellow, Aditya Kemka, I believe he's in Mumbai. Aditya.
Yes, I know him. Him, and he's been talking to me. But I mean, how complicated is the learning curve?
Yeah, I think that the learning curve, surgeons, certainly tumor surgeons, people that do complex trauma, arthroplasty, you would be familiar with these techniques. There is a learning curve, sure. And I first met Munjid, he had done 107 cases when I got there. Now we've done another 750 or whatever it is. So the learning curve, but he started off, he did 1 case his first year, 2 cases his second year, about 5 cases the third year. It took him 3 years to get up to the point where he'd done 8 to 10 cases. And I think that it's important to work together with the prosthetists and the physios and the rehab doctors, and the anesthetists have to be on board, and pain management is always an issue. And we have clinical psychologists. So you have to have this team of people behind you. I know that many surgeons think, oh yeah, I can do that. I can put this in. Yeah, that is the surgery is the easy part. It's managing the patient, selecting the patients, and it's more the bony part. Every person listening to me could master this within a period of 12, 15 cases. You would learn the technique of how you ream out. And now it is not normal bone. It's different for you as a tumor surgeon, because you will do, or you have normal bone above. You would cut something. It's normal. The guy was walking on that until the day you came in and amputated it. If you have someone who's been an amputee for 47 years and has never, or other people who have never walked on these limbs, the bone can be very, very osteoporotic, very, very hard to manage. So I'll say about 1/3 of the cases are pretty easy. And when you take this on, start with the easy ones. 1/3 of them are a challenge, and 1/3 of the ones that we do now are way outside the envelope of what you would consider normal.
Thank you, Manish, for those questions. Thank you, Kevin, for that wonderful eye-opener in the breakthrough innovation. Thank you very much. Now, the next talk in the breakthrough innovation in trauma is gaps in trauma and where the innovation needs to happen. I invite Dr. Joshua Gary for his talk. Gary, now it's all yours. Welcome.
Great. Good morning. Thank you for having me. Let me see. Is my screen presenting correctly now?
Yes, sir. Yeah.
Hey, Josh. Good to see you there.
Hey, Kevin, how are you? Great to see you. A lot easier than coming to Brisbane. Well, thank you all so much for having me. You know, my thoughts have been with your country as with all you're going through right now with COVID, and I'm hopeful things improve quickly. You know, we just saw a great talk on osseointegration and where things are going with amputation. I think trauma's come a very long way, but this morning I want to talk about the gaps in trauma and where the innovation needs to happen in the coming decades. I'm currently in Houston, Texas, but soon to be in Los Angeles, California. And so here are my disclosures. None are related specifically to this talk other than the involvement with Metric and a position there on the executive committee and PI multiple studies. So I want to start with a case example this morning, and these are things many of your surgeons will be familiar with too. It's a 30-year-old female. She was involved in a high-speed motor vehicle collision back in July of 2016. And we can see the x-rays here. She's got a severe pilon fracture with intra-articular extension. And then she has multiple debridement irrigations, and we actually fix her articular injury the night of, but she's got severe contamination within the bone, a non-viable bone, a 3B open wound. You can see that here. And so here we've fixed her joint, we've framed her. We've got a large bone gap, which I think presents challenges. I think what we just saw from Kevin may be a great functional option. And we talked to a patient about amputation, and she's not interested. She wants a reconstruction. So she gets a free flap with our plastic surgeon who does amazing work. And we wait. And here's what we have. You know, once we've gotten to this point in the salvage process, she's got segmental loss of her tibialis anterior muscle that can't be reconstructed. She's got segmental loss of her anteriotibial artery, which was used actually to plug in this free flap. And then she's got 7-centimeter loss of the metadiaphyseal distal tibia. And so that's where we are. And she's now had free tissue transfer and skin graft. And so what are options? You know, we're now starting to see some intramedullary devices that allow for lengthening over a rod, but those are just coming out and have had issues early on. So we did a bone transport on her, which we're familiar with. And here she is 3 months post-injury. Here she is 9 months post-injury as we're getting ready to convert this to a medullary nail with some regenerate proximally. And here she is 17 months post-injury. So we can see that we have regenerate, although I would call this an implant-dependent union proximally with the bone that's formed. We can see the ankle. We got an excellent articular reduction on her, but we've still gone on to some degree of arthrosis. Here's the patient's range of motion. You can see the free flap is healed well. So this is almost a year and a half after her injury. And is this as good as it gets? She's had 14 surgeries for this reconstruction, 12 months away from work. She's a barber or a hairdresser. She's got pain and limited motion in the ankle. She cannot work a full shift. And she's had a big strain on her interpersonal relationships and family life, which she had very strong social support from her family, but this has been challenging. And she still says it's worth it. I do think the talk we saw just a minute ago on the osseointegration for some of these injuries may change the profile with amputation, but this is how this patient felt. So If you have nerve loss, we saw Kevin talk some about targeted reinnervation and things you can do, but if there's segmental gaps in nerves, there can be nerve transfers, but they don't necessarily recover and do well. So nerve loss is a real problem we don't have good solutions for. And then this is one I just dealt with yesterday on call. So the heel pad degloving, or that plantar skin of the foot, if you're going to perform salvage, you can see here someone who's lost their great toe, and then you can see an area demarcating along the entire plantar aspect of the heel. Many other places our plastic surgeons can do free tissue transfers and skin grafts, but on the plantar aspect of the foot, if this is gone, we're generally heading towards amputation because there's not great ways to reconstruct this tissue. And so what about bone and cartilage? In some ways, I do think these have been easier than the soft tissue loss, because we have ways to either replace it or try to recreate something that will give us something functional, probably not as good as the initial cartilage. But from that first case we had, you can see we went here on the left from the lateral injury film, and we did direct reduction of all of these fragments. We saw these cartilaginous fragments, we clamped them, we reduced them, we compressed them, but you still see in the long run that cartilage apoptosis that occurs with time. And so when you don't have motion and that initial damage, I think in some ways the injury dooms us to arthritis, some degree of arthritis, no matter what, when there's an intra-articular injury. There has been some work from Iowa in the past looking at what's the result of impact on chondrocyte apoptosis, but this is still a challenge we face. What about osteochondral fragments? This was a patient that had a femoral head fracture dislocation, and we did a surgical dislocation with a digastric osteotomy, and you can see this large fragment from the femoral head where this had just been impacted on the remaining rim of the acetabulum. Reconstruction for this can definitely happen with a total hip arthroplasty, but challenges become of how do we have a piece that fits this and fits it in an acute setting. This is not something you can really plan for when it comes in the night before. And can we restore this and prevent arthrosis, especially in young patients? If this is an older patient, I think a total hip arthroplasty is a great operation. When you get down into 20 and 30-year-olds, or maybe even 16, 17-year-olds, is that the right operation at the time? It may be right now, but it's an opportunity for us as we go forward. Here's another patient off of a ATV accident, had a severe soft tissue injury, and then a severe lateral condylar injury, that has resulted in chronic patellofemoral instability. Overall, she's done well in walking, but what do we do with these fragments? How do we replace them? Right now, we can use cadavers, but again, in the acute setting, how do we do this when this just shows up on your doorstep the night of? Here's another patient who's 20 years old. He was skateboarding and had a fall and has a pretty severe split depression tibial plateau fracture. And we can see the degree of valgus that his knee went into by where the lateral joint in the remaining segment is, which is here. It's almost 90 degrees to the normal surface. And so here's what we did for him. We did open reduction internal fixation. You can see we've used a threaded wire to try to maintain. There was very, very little bone left, and then we've used some cement, and I think we've gotten an excellent reduction. This is him compared to his contralateral side. He didn't weight bear for 3 months after this injury. We used cement to try to prevent subsidence, but after beginning weight bearing, about 6 weeks, you can see he's collapsed down some. He's now in valgus, does not have a great limb, and is 20 years old, and also does not have insurance, which makes the longer-term reconstructive options difficult in terms of attaining allograft if that's the way to go for this. Other problems we see are diaphyseal gaps in the tibia. So we've seen a case of bone transport already. Here's a patient with an open midshaft tibia fracture. You can see the contamination on these bony fragments, which maintaining these we know is not a good idea. And so then you end up with diaphyseal gaps. And we have things now that we can do with either bone transport, or here's a case of a mascule, and you can see bone graft. This was obtained from the femur with a reamer irrigator aspirator and mixed with chips and BMP. And this is a younger patient with a large segmental bone gap. And with the rod, again, he does go on to heal this, but if you look at the quality of the bone where he's healed that, and that may improve over time, I would again call this an implant-dependent union. If we took the rod out, I think his risk of fracture would be extremely high. And I think this is a success, but we aren't restoring the normal anatomy with this procedure. And if there are any issues, mandate the rod coming out like infection, we can have real trouble. So when we look at what are the opportunities and gaps for innovation, what is the low-hanging fruit? I think we have opportunities, and I think the osseointegration is a great example of what we can do in the long run and those big planning, and we need to achieve for those. But what can we do in the next 5 to 10 years rather than the next 20 to 30 years? Well, I think one is this idea of functional recovery. A patient has a trauma and they may be out of work for 6, 12, 18 months, maybe forever. If we can get them recovered, how can we shorten that time so we're minimizing their time away from work and the time with the family? So how do we take them from a scene of injury? Well, here's a patient that had a pelvic ring disruption, acetabular fracture, and femoral neck fracture, and ends up with an excellent reduction in result, but it's 3 to 4 months until he's walking. Can we take this time to walking down to a week? Are there augments that allow us to walk earlier? Should we be allowing these patients to walk earlier with implants? I think those are questions we need to look at because it minimizes the impact on society and on the patient's lives. What about translation? So with research, how do we take things that are in the lab and get them to patients? We see so many exciting things at the bench or in animal studies, but moving these into patients, it's $1 million or millions dollar question because we need great research to know what treatments will help. So how do we mind that gap? One thing that did come from the Iraq and Afghanistan wars out of 9/11 was the DoD saw many injured soldiers. And I think this has even helped in the prosthetics. And you saw DARPA that Kevin mentioned. DoD in the United States, the Department of Defense, is heavily invested in musculoskeletal injury research. And Andy Pollack deserves a lot of credit for helping to lobby for this. And to date, there's been almost $300 million US, and it may be more now, that's been dedicated to multiple groups. And what's come out of that? Well, Metric is one that has come out of that, which is a large consortia of multiple level 1 trauma centers across the United States and now some in Canada as well. And it's got almost 10 years experience, if not more, and probably more than, actually this says 20, more than 30 prospective studies now evaluating how we treat orthopedic trauma and what are the best methods to get people back to function. And more than 15,000 patients enrolled. And some of these publications are just starting to come out after more than a decade of work of enrolling and following these patients, many in randomized trials. This has been funded by more than $120 million from the Department of Defense and now also some other funding sources. And this has experience and can help answer these questions of how do we improve care and how do we improve function? One large study headed by Bob O'Toole from the University of Maryland is Prevent Clot, which is now looking at simple questions as well of how do we prevent DVT and PE. This is going to wrap up enrollment this summer of more than 12,000 patients in a randomized study and should be the largest study in the history of orthopedic trauma by the time it's published. There are other centers as well. In Canada at McMaster, Mo Mandari has done a great job in collaboration with many folks like Paul Tornetta and many other OTA members that are on this call, where they've done several studies looking at some international, including simple questions of how should we irrigate the wounds? Does it need to be Castile soap, saline? Should we do high flow, low flow? The FAITH trial with Mark Swinkowski and Mo Mandari and others was a very large trial that's answering questions of which fixation constructs are best. I think the other thing we really need to understand is the equitable access to care. And so the World Health Organization has had a big focus on COVID in the past year, but we know that there are disparities in access to care, both internationally and even within the U.S. They've called them trauma deserts in the U.S. Some places don't have trauma centers, don't have level 1 trauma centers because there's not great funding for the patients. And so I think this is a big question, not only within countries, but worldwide, or how do we get patients to have access to care that can help restore their lives in the best way possible? The scale of the problem is huge. The money to support research on injury has not been very high for many funding sources. And here you can see the death per year in millions of injury compared to death from HIV, AIDS, TB, and malaria, which receive tens of millions of dollars in support from multiple organizations for research. That's not been the case with injury. We're going to see more and more deaths. It's going to continue to increase with road traffic injuries, going to be the 7th highest cause of death in 2030s on estimates from the WHO. And I know you're seeing this in India as well, with the traffic and the amount of road traffic and motorcycle injuries. And then if we look in our young working population, ages 15 to 29, that is the highest killer are the road traffic injuries. This is what's killing people, and even going into people 30 to 49 that have families. These are major causes of not only mortality, but long-term morbidity and disability for these patients. So how do we lobby our payers and our governments to increase this access and increase the ability to care for these patients? And we know that poor countries are worse affected by the injuries and violence. We can see that the injury deaths per 100,000 are higher in those countries that are lower income compared to those that are higher income. So here's a patient that I think a mature trauma system was really able to help him and save him. And I think a goal would be is how does the access that came to this patient come to every patient that's hit? He's a 20-year-old male. He was standing outside of a nightclub and got hit by a car and had severe injuries. He was in shock with emergency medical services and the ambulance arriving with a systolic blood pressure of 95. His heart rate was elevated. He had a pelvic ring disruption with a complete left SI injury, pubic symphysis disruption. He got to the level 1 after a trip on the helicopter where he could actually get a unit of blood in the helicopter on his way to the definitive hospital in the level 1 trauma center, still in shock with a low pH, base excess of -6. And you can see his hemoglobin looks good, but we know he's hemoconcentrated. Before he even got to the level 1 trauma center, he's getting a binder to try to limit mortality and morbidity. And again, here there's some great things you see. On the binder, doesn't have him perfectly reduced, but we can see the bladder in the contrast, signifying he's got a large hematoma because the bladder's not the normal size. The CT scans shows the severity of the injuries with acetabular fractures, SI dislocations, pubic symphysis disruptions, fractures to the anterior ring. And once he hits the door, with him being resuscitated, we're able to stabilize things percutaneously for him, get him well reduced, get him resuscitated, all within 6 to 8 hours of his injury. And at 3 months, we're able to fix him and we have him back walking. I think in the United States, in many cities and centers, several years ago or even decades ago, without mature trauma systems, he may have died from shock. But what does it require to take care of this patient and return him to function and return him to his life? It took ambulance services. It took outside hospitals. It took helicopter services with blood in the helicopter. It took a blood bank, not only in the helicopter, but at the hospital. It took angiographers to make sure he didn't have bleeding that needed to be coiled and that were rapidly available. It took a team in the ICU with general surgery, trauma, intensivists, orthopedics. It took newer imaging technologies that allowed us to see 3-dimensionally intraoperatively. And it took the orthopedic trauma surgeon. We're just one piece of the equation as the orthopedic surgeon for these complex patients. So I think the take-home points as we're wrapping up this morning on where can we innovate and where do we need to go in the coming decades, or trauma has similar gaps. We just need to have solutions more quickly for these patients. How do we advance the segmental soft tissue loss? How do we advance nerve loss? How do we advance bone loss and get patients back to function and get them and restore them to their lives? How can we decrease that time to recovery? How can we make a 6 or 12-month process to return a patient to work become a 1 month, 2 month, or even 2 to 4 week process? Those are all avenues we can do to decrease the cost to society. How do we use existing networks that are there? Not only networks within countries, but international networks. How do we link surgeons to determine what treatments are best and prove efficacy of what we do? And then how do we invest in trauma services worldwide so that all patients who are injured have access to that care? I want to thank you very much, and thank you so much for having me, and I'm open to any questions.
Thanks, Josh. That was really very, very stimulating talk and taking the entire array of possibilities way we should be thinking about. My question to you is, there has been, US has seen from no development to whatever the last case you depicted as most developed and most standard of care that can be offered for a polytrauma young guy. As you can realize, if you see globally, there are so many gaps still existing. Each country is different. Each country's protocol is different. What do you see in next 5-10 years? Where is the world going to be?
In some ways, I think COVID is probably delayed it even more, as we've had so much of a focus right now on the pandemic and coming out of that. I think the challenges in the world, or the population is still increasing. The motor vehicle collisions are still increasing. The other trauma is, without investment and without groups coming together and lobbying for that investment and the dollars we need to modernize those trauma systems. And, I think when we look at the United States, there are areas in the United States, and many of them are inner cities, where the care is not mature, and they have troubles even in a extremely well-developed country like the US. And I think it's going to take support from the OTA, from international orthopedic organizations like the IOA and others, to come together and say, all right, how do we advocate, for these patients and for the dollars we need to build systems where we can have those services ready and have those physicians supported. And it's not just one doctor. So I really think at the high levels, that's what, our organizations that take care of trauma need to be thinking and working together on.
Yeah, sure. I think last 6 months back, Ted McLeod has put a very beautiful article in OTA, Babe Journal, and we looked at all the trauma systems all over the world, and we compare them. But I'm sure it will take some time for us to be one world, So anyway, thank you very much. Any questions? Feel free to ask anyone on the panel. Thanks, Josh, for coming. Hi, Kevin. Good to see you.
Good to see you too.
If no questions, let's move on to the next point in agenda, which is the take-home messages. And I'm going to quickly share my screen. And so these are the take-home messages. And I request all the moderators, starting from me, to just show their screen or come on the screen and tell about their track take-home messages. I will start with me, then Mandeep Dhillon sir, Ram Chadda, Manish Agarwal, John, Hemant, Rajesh, Dilip, and KJ, in that order, please. So I will quickly stop there and start with me. So we had this upper extremity track on day one, and I was the director, and it was a pretty busy schedule from 6 to 9. In fact, we exceeded the time limit. We went on by another 15-20 minutes, I guess. JC Jupiter from Boston was the star of the show, as always. We talked about coronal shear fractures in his first talk, where he clearly told about the lateral approach and how to deal with reduction and various implants to fix these coronal shear fractures. In his second talk on non-union of distal humerus, he executed a very difficult non-union and suggested a 3-plate fixation, 2 plates on the lateral pillar, 1 on the medial side, and how to use this concept of 3-plate fixation. very effectively in non-union and use of bone grafts. In his third talk, which was on contracture release of stiff elbow, he demonstrated again with the help of surgery how he uses two incision technique, lateral and medial incision technique, to effectively release anterior and posterior contractures, and use of burr to deepen the reception fossas on the anterior and posterior side. And also he effectively told us about the posterior approach to go laterally and medially same time to take down the posterior bony contractures, if any. In his next talk, which was on surgical video description of scaphoid non-union, he talked about the approach, the grafting technique from radius, and how effectively you can still use a non-vascularized distal radius graft and achieve a good scaphoid union in most of the cases. Then was Michael Mckee, who spoke on clavicle fractures, when and how to fix them, how to choose clavicle to be fixed and use surgery as the preferred modality. Then in his second talk on proximal humerus fractures, he talked about his newer implant, which is a low profile clamp-on kind of a plate with a hook on top to deal with most of the complex variety of fractures of proximal humerus. And he suggested an effective way of a low profile plate, still mechanically strong, so as to take away the need of a huge plate sitting on the lateral side, use of suture anchors mostly, and still achieve a great functional result. In his third talk on maximizing the success in distal humerus fractures, he talked about some tips and tricks of fixation techniques. He talked about orthogonal versus parallel plate fixation, and how we can effectively use good surgical methodology to achieve good functional result in distal humerus. Dr. D.D. Tanna from India, he very eloquently showed surgical video on elbow fracture dislocation, talked about how instability is there and how one can tackle with that resultant instability by doing bony reconstruction as well as soft tissue reconstruction sequentially, so as to combat this very difficult problem of elbow dislocation. Prakash Kotwal, he talked about malunion in distal radius and the osteotomy which has to be undertaken. He believes mostly in a volar plating. He also talked about Shove-Kapanji procedure and how to exactly perform the procedure by using his surgical video. Sudhir Warrier took us back to effective use of external fixation on for comminuted distal radius fractures, and he told us very effectively how one can put a biplanar external fixation to deal with most of the difficult fractures, also comminuted distal radius, and how one can joystick the non-ligamentous attached bony fragments to effectively create an anatomical stable construct, make sure that you achieve a good vertical and radiocarpal height, which he thinks is very important for achieving a good functional result of distal radius fracture. Vidisha Kulkarni talked about proximal humerus fractures, and she described and demonstrated very well the use of Philos splitting for proximal humerus fracture, and how it is important to put these fractures in valgus, and the use of an oblique calcar screw for retaining what you achieve on day one. Once you open reduce most of these fractures, wherein she uses a deltopectoral approach for dealing with these fractures. I talked about acromioclavicular injuries, and I talked about the anatomical way of reconstructing acromioclavicular joint by using various tendon grafts and reconstructing the trapezoid and conoid part and using the excessive graft for acromioclavicular ligament reconstruction in type 3 onwards injuries. Then I talked about olecranon fractures, wherein I demonstrated various ways of fixation, and I specified about where one can use tension band wiring, where one can use plating and one has to use plating, and various ways one can also deal with shortening and plating and the use of grafts from the same war zone. So that was all about the upper limb track, and it was a very fruitful discussion by the participants, and everyone really enjoyed. So I really want to thank at this point in time Integrace for putting this together and Insignia Learning for making this happen. Thank you very much. I suggest all the next moderators to come on their own and tell us about their take-home messages. Thank you.
Thank you very much, Sushrut. This is Ram Chadda. I am coming out of term because Mandeep is unable to join immediately. So I am next in line. I was privileged to be the director for the spine trauma section, which was on day 1. We were given 90 minutes, and using the first mover advantage, we stretched the discussions to about 100 plus minutes, thanks to Manish Agarwal being courteous enough to allow us a little bit of time. We had the good offices and the presence of Tim Moore from Cleveland, Ohio, a very, very talented, brilliant spine surgeon who shared his experience of more than 2 decades managing spinal trauma in a tertiary care center. We had excellent interaction. A lot of things that we picked up from Tim. One is a lovely video which he showed to us of how he reduces thoracolumbar dislocations. A very genuine orthopedic way of looking at it, but something which not many people have thought of. What he does is that let's believe that there is a D11, D12 dislocation, almost a complete translocation. What most people would do would be put in screws into D10, D11, D12 and L1, maybe one above, maybe one below, and try and get a good reduction. But something which was brilliant, which was purely orthopedic, is that rather than use vertical rods, he used temporary transverse rods and got a good hold on either side and did an absolute orthopedic reduction, because here we are not looking at neurology. These patients are normally totally shut down, and found a very brilliant way of putting transverse rods, which means that the left pedicle of D11 was connected to the right pedicle of D11, and so was it across from 12 to 12, and this translocation or dislocation was beautifully corrected. So that was a lovely take home that he shared with us. He then went ahead to make a presentation on C1, C2, which was again a video presentation, and occipitocervical fixations, where he made a lovely point again. Rather than struggle to get a contoured rod going from the occiput and going into C1 arch and coming back, he would keep his C1 screws a little longer. He would in fact leave the central part of the skull open and use buttons on the rights on either side, having a good area for bone graft or fusion to come in. So these were two very, very interesting points that he shared. One, keeping the C1 screw longer. Normally we would put a 16 or an 18. He would put a 40 millimeter C1 screw on either side and a shorter C2 pars or a C2 pedicle and go into the occiput. So the construct would be such that he could incorporate bone graft there, as well as use bands or atlas cables to enhance support to the graft. Another excellent take home in that video. Finally, he made a brilliant presentation on sacral fractures And believe me, this is a transient zone between axial skeletal surgeons and appendicular skeletal surgeons. So the sacral fractures is somewhere a watershed where spine surgeons as well as the orthopedic trauma guys work together. But yes, there is a place where the two teams need to work together, especially where you need to actually, one, stabilize the spine to the pelvis, especially in those bad comminuted type 2 plus sacral injuries, where you need to have some control over L5 or maybe even up to L4 and have those large constructs going across, which are very, very mandatory to get a stabilization or a tamponade even on day one salvage surgery. So that's excellent. And we had lovely presentations from him. Dr. Vishal Kundnani, who was the other Indian faculty, and we went through showing standard classifications for thoracolumbar spine, which Vishal did, and for the cervical spine, which I did. And we also added videos for the thoracolumbar spine, which I showed, and an excellent presentation on odontoid fractures, which was shown by Vishal Kundnani. Having said and done all this, we ended the day with something which is very, very crucial for us today, which is osteoporotic fractures. We were running short of time, so we just had take-home messages, and we shared basically salient points of how to manage osteoporotic vertebral compression fractures, which are usually without neurology, and almost 90% of them are amenable to non-invasive care. So this is, in short, in a nutshell, what we covered in the trauma subsection of this OTA boot webinar. I thank you for having given us a chance. 90 minutes was worth it. We stretched it to 100 plus, and maybe next time we'll have some more time. Thank you so much.
Should I come on now, or would Mandeep be coming?
Manish, you can take over.
Okay. So we had a little different format. Instead of lectures, we had a case-based discussion on path fractures. I'm extremely grateful that pathological fractures has been included in the discussion along with regular fractures, because the people who generally manage pathological fractures are the same as people who do trauma, but the pathological fractures are completely different in the way they require to be managed. So it's very important to discuss it. And this has not happened either at postgraduate level or in many of our meetings where the regular trauma actually is more glamorous and more interesting. So, 1 minute, I think. I'll just get the points which are required. So what is very important is that we have to first recognize that there is a pathological fracture. And this was one case where I think a proper history was not taken, and the history is the actual clue when the trauma is trivial. So you may not see very overt signs on the first X-ray, but this is very, very crucial, whether it's a neck femur fracture or whether it's any other fracture, particularly in the young. To suspect a path fracture, the history is extremely important. And once we know that the fracture is pathological, it is important not to assume it's benign. It requires a full workup, otherwise we create disasters. Like in this patient, it is assumed to be benign, was nailed, and then you have contamination all through the bone. Sometimes very difficult to salvage, and patient may never recover to good function. Again, very different from the usual fractures is that, yes, there is a fracture, patient is in pain, but pathological fractures are not a fire brigade emergency. You need to spend a few days, maybe 2 or 3 days in a workup that requires imaging, definitely an MRI. It requires sometimes a PET CT if you're suspecting metastatic disease, and it clearly requires a biopsy, because unless you know what we are dealing with, we can't deal with it in the correct way. So again, if you look at metastatic fractures, it cannot be just the orthopedic surgeon which is managing these fractures, and this was stressed by everybody. We had a big multidisciplinary team to emphasize this. You need radiologists, you need pathologists, you require medical oncologists, interventional radiologists, nuclear medicine people, you require radiation oncologists, and then the surgeon has to formulate a plan because he has to estimate survival. He has to estimate what's going to be the systemic therapy, what are the radiation needs, and then plan his surgery, because any reconstruction that we are going to use has to outlive the patient. And this again was stressed. Dr. Chafey in his initial part actually outlined all the steps that are important in path fracture to avoid failures. And the most important thing is, if a patient is going to live long, and you know that this is a tumor which is not responsive to either chemotherapy or radiation, it is better to resect and replace rather than try to do a fixation. So at the end of it, again, the short message was that you require to think differently for pathological fractures, and you need to have a treatment plan, which often will require a multidisciplinary input. Thank you. The next speaker can take over now.
If I were to interrupt, what looks like Dr. John Mukhopadhyay, Hemant, they are not there. So Dr. Rajesh Malhotra, could you please step forward?
Sure, I don't mind filling in up for anybody. Can I start sharing my screen? Okay. Okay, so we had a very interesting session. We had the foreign faculty, Dr. Paul Tornetta and Dr. Hassan Meet, and we had Indian faculty of Dr. Vivek Trikha, myself, and Dr. Vikas Agashe. So it started with Dr. Paul Tornetta, who gave a talk on his way of treating the symphysis injury. And he says that whenever he is fixing these symphysis, he just takes out the cartilage from both the sides. It just takes him a couple of minutes. And he showed from his paper that he is able to achieve better compression, and he can bring the both sides of the symphysis closer, and it gives him good results, and he showed a lot of literature. That was followed by Dr. Hassan Meet's talk, where he showed that he always likes to assess under anesthesia the stability in the APC and LC type of the pelvis fracture. So he takes special views. So he takes the inlet views, the outlet views, the AP views, and then each of these views, he takes an internal rotation, external rotation, and he also then stresses the pelvis, and any kind of movement which he can see signifies the instability, and then he treats it accordingly. He has published extensively on that. The whole idea of his presentation was that we should have high index of suspicion for instability in APC and LC injuries, and you should always, if you decide to treat something conservatively, you must always do an examination under anesthesia to rule out subtle instability which can create symptoms later on. Then there was a complex pelvis case presentation with Dr. Vivek Trikha, and in which he showed a rare kind of injury. It was a lateral compression which led to the anterior dislocation, fractured dislocation of sacroiliac joint, and it was discussed that it can be treated by a lateral window and stopas, which the foreign faculty felt, but he said he would always like to treat it from the lateral window and always take a look at the L5 nerve root and the
protect the neurovascular structures and fix it. Overall, it was a very interesting discussion. Dr. Paul Tornetta showed a case of polytrauma in which he had fixed with 2 screws, and the patient had head injury, and the patient became unstable. So they decided to give the traction because the other side sacroiliac joint was also dislocated. They decided to put the patient on skeletal traction, shifted to ICU, and 3 days later, when he came back from a conference, found that everything had come apart. So rather than losing his cool, I think he saw that the screws had backed out. So what he did was he put the K wires back into the screws and forwarded them through the opposite sacroiliac joint, and then he put the longer screws, and in supine position could be done very well. I think the message which went there was that you should really weigh because there were various opinions as to how one would have addressed it, but I think it was a very clever thinking to put the K wires through the old tracks through the screws which had backed out, and then put in longer screws and fix both the sacroiliac joints with the screw to the same corridor. We had a talk by Hassan Mir then, which was the acetabular fixation via the anterior intrapelvic approach. They have done some nice cadaveric, very elegant cadaveric studies showing that you can approach 2 centimeter of the bone above the brim and 5 centimeter below the brim, and how you can even fix the posterior column through the anterior intrapelvic approach, and can handle a lot of complex injuries where you can just combine it with the lateral window. So it was a very interesting video, followed by my talk on arthroplasty and acetabular fractures. Essentially, the thrust was on the 10 commandments of ruling out the infection and making sure that the neurovascular bundles are away, and assessing the bone deficit. And also I showed the cases where the acute pelvic discontinuity, where we have been doing cup cage for several years now, and we have published. I actually presented my series where the initial 15 cases which we did with either the ZCA cup cemented inside the cup cage, or the constraint cup, or in the later part of the study, the liner of a cementless trilogy cup were cemented inside the shell, to the current times when we use the dual mobility. So we have 16 patients of the pelvic discontinuity following acetabular fracture, treated with cup cage, and cemented a dual mobility cup in that without any dislocation. Then we had a complex acetabular case presentation by Dr. Vivek Trikha, and essentially from the facts which came out from the discussion about the acetabular fracture was that if you have a very high transtectal transverse fracture, particularly if it looks oblique and part of the dome is involved, it is better to approach it from the anterior approach, even though the faculty agreed for the most transverse fractures, they would like to approach it by the posterior approach. We had a talk by Dr. Vikas Agashe then on tips and tricks of intertrochanteric fracture, and he emphasized how continuity of the anteromedial cortex is paramount, and he showed some interesting cases even in the case discussion about how to deal with this common problem. I presented on the talk on intracapsular fracture neck femur, essentially about what is the current status of fixation of the undisplaced femoral neck fractures, and the role of hemiarthroplasty in older people, even in the undisplaced fractures, and the role of CT scan in evaluating these undisplaced or the impacted fractures to decide whether we should fix it or we should go for the total hip replacement, followed by the various biomechanical studies which show which configuration for fracture neck femur screw fixation is strong, and then the comparison of the sliding hip screws with the multiple canceller screws. Most people agree that for Powell's 3 or vertical type of fractures, you get more stability with the DHS, with the derotation screw. But then I also discussed the role of Powell screw and a medial cortex plate for fracture neck of femur. And in the end, I discussed the femoral neck system, which is a new kid on the block, and told about the biomechanical studies showing how it fares mechanically as strong as the dynamic or the sliding hip screw systems, as well as with derotation screw, as well as with the multiple screws. But the catch is that there's not enough literature available yet. There was a registry which was expected to include 125 patients in USA, which was supposed to be completed on 31st July this year. But I doubt that that is going to come through because of the pandemic. We had a few questions. There was a question about how to ensure medial entry in a very obese patient, and Dr. Paul Tornetta felt that you should take such patients on their side in the lateral position, and then it should really not be an issue. There were questions about the augmentation with PMMA, about the osteoporotic intertrochanteric fractures, but then at least both the foreign faculty members felt that that is not really something which they try. On the other hand, they are looking forward to the calcium sulfate cements or the other kind of bone substitute which work as the cement, which gives better result. There was another question about a combination of plate and nail for intertrochanteric fractures, which was not put yesterday. We saw it today at 9:30. It was quite late, but the foreign faculty did not sort of have any experience of combining a nail with the plate. In fact, when we discussed the failure of the fixation of proximal femoral fractures, the Dr. Hassan Mir was quite emphatic that he would treat a failure of a nail only with a nail. Although Dr. Paul Tornetta, myself, and Dr. Vivek Trikha did think that there is a role of condylar blade plate in these cases, the fixed angle devices, provided you correct the varus and freshen the bone edges. Particularly, one of the cases was of atypical fracture, and give compression. And then, of course, I also did say that we have published about intramedullary fibula in difficult humerus fractures, and we use that in the femoral cases as well, where its fibula can work as an intramedullary fixation device and also span the fracture site, and you can actually also graft it. And then, of course, what was also discussed was the role of parathyroid hormone injections, especially for osteoporotic bones as well as atypical femoral fractures. So it was a very interesting session. I think both Paul Tornetta as well as Hassan Mir were forthcoming, and we had very good discussion, and we had good support from the Indian faculty. Thank you very much. So, John, the floor is all yours.
Okay, fine, great. So yesterday we had the knee trauma module. So I'm just going to go through the highlights of the program. So let me just see if I can get this to open on that. Yeah. So in the faculty, we had Dr. Della Rocca from Columbia, Missouri, and Dr. Arvind von Kudel from Boston, Massachusetts. Okay, and in the Indian faculty, we had Dr. Hemant Kalyan as the co-chairman for the course, and we had Dr. Dheenadhayalan from Ganga Hospital and Dr. Rajiv Chatterjee from Kolkata. So I think all the faculty from India at least are well known to most people. So we started with the first session, which was on surgical approaches. I think first Dr. Della Rocca talked about most of the anterior approaches as well as the posteromedial approach in the supine position. And then Dr. Arvind von Kudel talked about the posterior approaches and when you would go posterior for some of these tibial condyle fractures. So I think both the talks were very enlightening. They were precise and to the point, and had good diagrams to explain, as well as clinical pictures to explain the approaches. We then went on to the distal femur fracture session. Okay, we started with a talk on management of intra-articular distal femoral fractures by Della, Rocca. And I think this covered most of the problems that we face, including the reduction techniques, how you judge the alignment, little tricks to get the reduction, use of the distractor, etc., were sort of elaborated in the talk. And he also showed cases to go along with it. I think he did not show any cases of double plating, though in the discussion that followed, he did say that he did use double plating in some of the situations. So I think there is a role for it, but in my own practice, we use it only for very specific situations, not just for comminution on the medial side. So I think if you just have a comminuted fracture with metaphyseal comminution, usually if you use a long enough plate and bridge it, it works well. Occasionally you'll have a posteromedial condyle which needs buttressing on the medial side. And of course, in some of the very distal periprosthetic fractures in osteoporotic bone, probably a medial plate is useful. Then I talked about malunions of the distal femur. So we did, it was really a case-based talk on cases including extra-articular malunions in Hoffa fractures, and intra-articular malunions. So intra-articular malunions in Hoffa fractures as well as condylar fractures. So medial condyle fracture which had malunited, as well as a couple of Hoffa fractures which were causing intra-articular step-offs, which we did intra-articular osteotomies and corrected, showing good results with them. So the main aim of this talk was to show that I think your planning is important. You need to assess where the deformities are and then do your osteotomies planned in a manner that you address the problems that you have to deal with. This was followed by a talk by Dr. Dheenadhayalan from Ganga Hospital on management of bone loss in distal femur fractures. So I think he showed some excellent cases, and especially the Kapana technique, which is a combination of using distal femur allograft along with a vascularized fibula graft, which they have also published recently. And he showed some very good results using this technique for large bone gaps. So their role, they tended to use this for large defects as long as the soft tissue condition was reasonable and the patient did not have other comorbidities or major problems with polytrauma. In those situations, they might prefer transport. He also then talked about distal femur malunions and non-unions, where he emphasized the need for compression across these non-unions. And he also used, in many of them, fibular strut grafts to augment the fixation on the medial side, especially to get good results with the fixation of these difficult non-unions. So that was an excellent session. There were a lot of questions on various techniques. And this was then followed by a session on proximal tibial fractures. Here, Dr. Arvind von Kudel first talked about the medial tibial plateau fractures and fracture dislocations, and talked about when you need to go lateral in these particular fractures. So a lot of the medial condyle fractures will also have splaying on the medial side, on the lateral side, with the lateral part of the tibia subluxating out of the joint. Many of these medial condyle fractures are actually fracture dislocations, so he emphasized on that point. You need to, of course, rule out vascular injuries and neurological injuries in these fractures, but he also emphasized that some of these fractures, even though the fracture may just be on the medial side, you also need to go laterally, do a submeniscal arthrotomy on the lateral side. They could be associated with meniscal injuries as well as ligamentous injuries, so which you also need to be aware of. And sometimes without going laterally, it's difficult to get the lateral part of the condyle reduced adequately. And that's why you sometimes find that even after your fixation, the lateral part of the tibia is still subluxed out a little bit, and that may lead to problems later. Then Dr. Greg Della Rocca talked about bicondylar tibial plateau fractures and talked about where a single plate would be adequate and where you need to use dual plates. So he talked about where when there was a posteromedial fragment, it was difficult to capture this with the lateral plate, even if you used locking plates, and they almost always needed a posteromedial buttress plate along with your lateral plate. While there were some fracture patterns, especially where the medial condyle was a large chunk, it wasn't just posteromedial, it included the entire medial condyle, and there wasn't too much of a cortical defect on the medial side, where with a lateral locking plate, as long as you used the plate that was strong enough and long enough and got adequate screws onto the medial condyle, you may be able to get away with one plate. But he did emphasize that wherever in doubt, use two plates rather than one. So, but there were some situations where a single plate would be adequate, and sometimes where the soft tissue is not so good, this may be an advantage. Then we had Dr. Rajiv Chatterjee talk about complications in proximal tibial fracture. And here the emphasis was in the initial assessment to make sure that the soft tissue was not ignored. I think if you ignored the soft tissue, it was at your peril and you would end up with disasters, with wound breakdown, etc. He talked about compartment syndrome, the need to be aware of it and to deal with them adequately and promptly if you diagnose compartment syndrome, which is essentially a clinical diagnosis, but there were situations where maybe the use of a compartment pressure monitoring system would be useful. He also talked about some of the problems with fixation, which led to malunion, especially where there was a depression of the posteromedial fragment. If you did not buttress it posteromedially and you just put a plate on the medial side, it may not be adequate. And he talked about infection and some of the non-unions that you might get in these situations. So, and we ended up with a case by Dr. Greg Della Rocca of a case of compartment syndrome, which was missed in the initial diagnosis or, was initially treated somewhere else where they put a cast on and then he had severe pain and then he came to their center a day later. But luckily, it was in time for them to be able to decompress it. He emphasized that he preferred doing a 2-incision decompression rather than a single lateral incision for the compartment syndrome decompression in these cases. And then he showed the follow-up, and the usual practice would be to put an external fixator at the time of the decompression and do your definitive fixation once the soft tissue had settled down. There were some questions on whether you could do the decompression and fixation at the same time, and he did say that yes, it may be possible, but his preference was to do it in 2 stages because that would avoid some of the problems that you might have with a single stage fixation. That ended the proximal tibial session. And the last session was on periprosthetic fractures. So there, Dr. Arvind von Kudel talked to us about how the femoral distractor would be a useful instrument when you're dealing with these fractures because it helped to get everything out to length, and then you could use joysticks to correct the sort of distal femur fragment if you needed to get the alignment right with the proximal femur, or you could use a bump to help you get your reduction because of the tendency of the distal fragment to go into extension. So I think this was, again, a useful technique that he showed. Dr. Rajiv Chatterjee presented another case where he could manage a fairly distal sort of periprosthetic fracture, but it had quite a long medial fragment, which he could get with a cross-through across, and he managed with a single plate, but did emphasize the need for double plates when the fractures were very distal and you were unable to get adequate screws into the distal fragment from one side. Distal femur periprosthetic fractures, which he treated with plates. One was a failure from somewhere else, where he had to use 2 plates to get it corrected and get it to heal. So I think it was, on the whole, a very fruitful session. There were a lot of questions. I believe it was one of the modules which was best attended, so that was good. And certainly had the maximum number of questions from the participants. So I think overall it was a very satisfactory session, and I hope the delegates gained something from it. I'd be fairly keen to know about the feedback about this session. So thank you.
Thank you, Dr. John. I am Dr. Dilip Shah. I'll be taking over if you allow me to share my screen, sir.
Yeah, I'll just stop sharing. Okay. Okay, Dilip, good to meet you.
Hi, how are you, sir?
Good.
Can you believe that by not attending any of those sessions which we have missed out, people have explained so lucidly that I almost felt that I have attended all the sessions. Really, you people elaborated so well, I must tell you. So by the time my screen comes up, I wanted to talk to you people that we were given, me and along with me, Dr. KJ Reddy from Hyderabad. We were thrown upon infaction. I don't know, people didn't want to take it, or they thought that we are either the best people or the worst people to take over infaction. So me, along with Dr. Reddy, took up the challenge and made it into infactions and non-unions. We had very eminent speakers, Dr. Kevin Tetsworth from Brisbane, Australia, and Dr. Peter Giannoudis from Leeds, UK. And our IOA president, Dr. B. Shivashankar, as one of the speakers, along with Dr. Ritab Kumar from New Delhi, India. We had lots of lectures and case discussions on infections and non-unions. Now, I'll give you the take-home messages. Treatment of chronic osteomyelitis by Dr. Peter. Management of chronic osteomyelitis remains challenging. Multidisciplinary approach is essential. Treatment should be tailored to each patient according to the severity and duration of symptoms, as well as the clinical and radiological response to the treatment. A combined antimicrobial and surgical treatment should be considered in all cases, including appropriate dead space management and subsequent reconstruction. Relapse can occur, which has a major impact on the quality of life of patients and is substantial financial burden to any healthcare system. I talked about preventive because I always feel prevention is better than cure. And then I'll tell you something about what I feel. That we always say that I treat and he cures, but then if you have treated and if patient gets infection, it's your bounden duty that you cure it. I had taken quite a lot of points. If you want, you can take a screenshot and see this website, Global Guidelines for the Prevention of Surgical Site Infection. In fact, Dr. Shobit of Integrace had insisted that you go through it. So I divided into 3 parts. Pre-operative, patient should bathe or shower prior to surgery, but there is no recommendation of chlorhexidine. Intranasal application of mupirocin 2% ointments if there is Staphylococcus aureus. Antimicrobial prophylaxis should be given within half to 1 hour prior to incision. Hair removal just prior to surgery, and if there is not too much of hair, do not make too much bone about hair and don't shave. Antimicrobial skin sealants. When I said it should not be used, everybody pounced on me, and it looked like I had stirred the hornet's nest. And then that's why I gave you to begin with from where I had picked up. 2% chlorhexidine combined with 70% isopropyl alcohol versus 10% povidone iodine. They can be used. Recognition of skin bacteria over time needs to be respected, and particularly if you have long hours of your surgery, then another dose of antibiotic should be given. 80% of inspired oxygen intraoperatively if feasible, and immediate postoperatively for 2 to 6 hours. Use of warmers, double gloves, and change the outer glove frequently, and a right-handed person needs to change left-hand glove frequently. Blood glucose control, whether diabetic or non-diabetic, is very essential. Laminar airflow is a very questionable thing, and from Germany and Switzerland, they decided laminar airflow does not do any good, but it's your choice. HEPA filters are the best, and UV lights, it has got positive role, but it can be detrimental if it is on when you are working, so you have to be careful. Then I talked about challenges in wound management, and especially in fresh injuries, you have to really look after vein, artery, nerve, tendon, bone. Gustilo-Anderson type 3B has maximum infarction. Whenever you cannot close the wound, use the negative pressure VEC therapy. Then Dr. KJ Reddy from Hyderabad spoke about recent advances in periprosthetic infections. Treatment options are antibiotic suppression, debridement, washout, and liner changes, excision arthroplasty, arthrodesis, debrima, partial revision, single-stage revision, two-stage revision, multi-stage revision, limb ablation, amputation. Two-stage revision, all complex cases, immunosuppressed, systemic disease, concurrent sepsis, reinfection, bone loss, the organism polymicrobial infection, MRSA, MRSE, unusual commensals, unusual resistance profile, or no organism. Take-home message is prevention. At selection, intra-op, theater discipline, prophylactic antibiotics, early diagnosis. Dire, acute and established infection, well-fixed implants, partial retention, single-stage selective circumstances. Non-organism, two-stage, interval based on response, freedom of reconstruction, complex case. Then Dr. Kevin Tetsworth from Australia. It was almost 2 a.m. for him. Fracture-related infections. Gram-Stein status, characterize the host, a host or B host. Characterize the organism sensitive or resistant. To retain implants must be sensitive to biofilm active agent, gram-positive, rifampicin, gram-negative, ciprofloxacin. Stability, loose plate or an IM nail. Time, 10-day limit, 10 days or less, evolving. More than 10 days is established. 1 to 3 weeks, gray area depends on host, organism, biofilm active agent susceptibility, and stability. A surgical condition, medical management to address immune deficiencies, quality of debrima, the single most important consideration, technically demanding, complex decisions, requires the most experienced surgeon available. Then Dr. Peter from Leeds, UK, he talked about surgical site pelvic infections and their management. Pelvic infections, the prevalence of the SSI after pelvic ring injury stabilization is low, 2.1%. Most common pathogen is MRSA. Patients with SSI required multiple trips or to the operation theater and prolonged antibiotic therapy. SSI development results to increased LOH. A multidisciplinary team approach is required to optimize the outcomes. Risk factors, diabetes, open fractures, degloving, lesions, bleeding, transfusion, post-traumatic immunoparalysis, New identified factors are injury severity, ISS, diabetes, posterior sacral fixation, alcohol. We really learned that when we try to teach, actually we learn a lot. And that was the consensus in our group. And I thank Integrace for integrating us gracefully. I thank OTA to really be with us whenever we needed. But at this juncture, India is suffering from COVID, and the suggestions for COVID are no routine surgery unless it's absolutely mandatory. If emergency, RT-PCR if negative or not, take all precautions. No helmet and Charlie space suit also should not be worn because you are breathing the same air again and again, which may be contaminated. Regional anesthesia is preferred over GA. Power instruments at low speed. Cautery minimal use and suck the smoke. Minimum number of people in as well as gadgets and less movements in OT personnel. Post-op COVID negative patients may become positive. So all the precautions should be maintained throughout. I thank you very much. And may I request my fellow director of the course, Dr. KJ Reddy, to take over. I'll stop sharing my screen.
Good evening. Thank you very much, Dr. Shah. That was a wonderful briefing of the meeting. I'll just share the screen. If you let me share the screen.
You can.
Yeah, okay. Yeah, just good. So it was a wonderful session, as Dr. Shah explained yesterday. We had a lot of questions, a lot of discussion. Most of the talks were case-based, which stimulated discussions. And Dr. Peter Giannoudis from Leeds talked about muscular technique. He said it's a good technique to consider the treatment of infected non-union with bone defects, essential during both stages to debride bone and ensure there is no residual infection left. Augmentation of bone with stem cells and growth factor can enhance the healing. Defects up to 25 centimeters can be treated. Good results can be expected, and he showed excellent cases and his publication, which were very interesting. And our president, Dr. Shivashankar, talked about exchange nailing in the proximal femur, giving example of excellent case. And his conclusion was shorter walking length by using a thicker nail and local augmentation plates, removal of avascular bone ends, augment biology with bone grafts if fracture is opened. Compression plating is also a very good option, especially in those cases. And we had great speaker, Kevin Tetsworth. We had excellent discussion, case presentation with him. He, principles of treatment of tibial non-union, he was saying that typically it's a staged, two-staged management. Debride all vital, devitalized tissue, remove all foreign material, preserve local vascularity. Stability should be achieved by external fixation, IM nails or plates. Local antibiotic spaces can be used. Soft tissue coverage is important. Pathogen-specific antibiotics, and delay return to the bone reconstruction. And there was excellent case demonstration as well as discussion during his lecture. Dr. Ritab Kumar from Delhi showed excellent demonstration of his cases. He showed a case of immediate post-op infection where on day 2, I think there was a plan for discharge, but he wasn't happy to discharge the patient because the wound wasn't looking good. So he suspected infection and took him to theater. There was infection and he treated very well. He gave the principles of management of acute infection, especially biofilm type of antibiotics, and how you manage the soft tissue coverage. Once the patient was treated well, he was discharged, and it was excellent discussion following his lecture. This was another lecture by Kevin Tetsworth about decision making in segmental bone defects. It's a complex decision depending on age, gender, location, whether it's a tibia, femur, soft tissue defect, size of the defects, whether there is any infection, and also should understand patient expectations and motivation, patient social situation and support, surgical skills, experience, hospital research, as well as cost, and he demonstrated excellent cases and the methods, bone transplant methods. He explained about conventional Elizardo bone transplant, unilateral rail transport, stacked exopod, unilateral cable transport over a nail, balanced cable transport, telescopic nail, demonstrated some cases, plate-assisted bone segment transport, universal nail adapting tube, and bone transport nail. And there was quite a few interesting cases in his talk. There was a discussion, and we had excellent discussion. As I said yesterday, every orthopedic surgeon nightmare would be infection, both in orthoplasty as well as in trauma. So when you're treating patients with orthoplasty or trauma, you should be able to manage these complications, especially infection, and of course, non-union as well. Thank you very much for your patient listening.
Okay. Great. So, have we finished, or do we have to do anything else after this? Finish?
No, sir. If
the final remarks by Prashant, sir.
Okay.
Thank you, sir. Thanks a lot, Dr. Shah, Dr. Mukherjee. So first of all, I think that this has been a great learning experience for all the delegates. I can vouch for the interest which is visible very much on our videos across the platforms, and this has been really a great learning experience for last 3 days. And as a company, Integrace is proudly associated, and we take pride in having 3 back-to-back best of orthopedic techniques programs done in association with OTA for last 3 years. And I'm sure that this year we are going to surpass our the participation from the last year. And we are really glad that we have been able to connect the leading orthopedicians across the world as well as in India with the orthopedic fraternity in India. So on behalf of all the delegates, let me first start by thanking all our guests from OTA. I think Dr. Vallier, wonderful oration. Thank you so much. The same for Dr. Tetsworth and Dr. Gary. And, all other OTA faculty members, thank you, a heartfelt thank you to all of you for sharing your knowledge, with all the delegates in India and abroad. Coming to Dr. Shivashankar, thanks a lot, sir. As a representative of IUA, I think the value of this program went multifold up because of your presence and your conducting the event. So thanks a lot, Dr. Shivashankar. Coming to our esteemed program directors, no amount of thanks would be enough. To say that without you, sirs, it will not be possible for us to run this program, the way we have done. So Dr. Babhulkar, Dr. Dhillon, Dr. Ram Chadha, Dr. Manish Agrawal, Dr. Mukhopadhyay, Dr. Hemant Kalyan, Dr. Rajesh Malhotra, Dr. Dilip Shah, and Dr. KJ Reddy. Thank you so much. Thanks a lot, for all your support, that you have provided in the way you have run this event beautifully. We are all, really thankful to you for that. Last but not the least, our partners, the knowledge partner Insignia. I think, the Insignia team has done, a fabulous job in kind of coordinating, the entire program and keeping it, running it seamlessly for the benefit of all the delegates. So as our IT partners co-act, who have run this entire program without any glitch, and the nameless countless other people from the background, including the Integrace team, Integrace IT team, Integrace sales team. Thank you so much. Thanks a lot, and we look forward to connect again with you very soon with a program of equally or maybe more intellectual. Until that time, please take care of yourselves, be safe, and to all the doctors, thanks a lot for being the COVID warriors that you are. Thank you, everybody. Good night, and
do not conclude. I want to request all the people, even from Insignia and from Integrace, to put on their video and let's have a screenshot smiling, because this is the end of it. Last 2 seconds, please. Shikar, Akshat, Tanisha, your videos on, please. Akshat, Tanisha. Okay, smile, yes, everyone.
Who's doing the screenshot?
I'll send it to you.
Okay.
One more.
That was great.
That was great. Thank you very much, all of you.
Hi, Rajesh. Hi, John. Take care.
Thank you very much, everyone. It was really great having you.
Can we stop the live feed, please? Can we?